Hi, it's Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County, and we're doing a Facebook Live today from my home today on New Year's Day. All right, so we have a little problems, that's why I got started a little bit late, but this is a chance for you to ask questions. Just put the questions in the chat section and we'll get to them as soon as we can. So, as we always do, we start with the world at the top and then move down. So at the world, we're at 84 million cases, 1.8 million deaths. The case counts in the world and the US are somewhat flat over this last week. But again, let us remind you that cases and deaths and tests during holiday weeks are very much subject to problems. And they're subject to problems because sometimes they don't get done, especially testing, and many times they don't get recorded. So although the cases do occur and deaths do occur, they certainly don't all get reported. So in the world, 84 million cases, 1.8 million deaths. Still very active in the US, in India, in UK, in Russia, Italy, France, India, UK, Sweden, the Czech Republic, and Panama. But again, sadly, the US has as many cases yesterday as all of those other countries combined. So when we look at all those other active countries, they really are having fewer cases combined than we do in the United States. And still, there are parts of the world that are relatively not affected. So New Zealand had 5 cases, Taiwan had 2 cases, China had 25 cases, Hong Kong had 68 cases, and Australia had 24 cases. So again, huge swath of the world here has very, very, very few cases. We've also in the world been following the story of Norway, Finland, and Sweden. So you remember your geography, 3 Scandinavian countries, Norway, going west to east, Norway, Sweden, and Finland. Sweden is the largest country of the 3 and has about as many people as Norway and Finland combined. So when we look at Norway and Finland, they had 557 and 249 cases. So, about 800 cases for the day. But Sweden had 5,904. So remember, Sweden took the approach that we were going to let this go through early, develop enough people who had natural immunity because of the disease, so that we may suffer in the first wave, but in the second and third wave, they would be protected. Well, that has been a disaster, and Sweden now has many more cases than its neighboring countries. In the US, we reached the sad milestone of 20 million cases, and 354,000 deaths. Again, the numbers over the last week you have to take really with a grain of salt because of the delays. Now, the one number that you can really trust is hospitalizations. The hospitalization rates are presented every day. When you look at the variability of the day-to-day curves for deaths and cases, there's lots of variability, much lower counts on the weekends and then higher counts during the week. But the hospital is a very smooth curve. And the hospital, sadly, is continuing to go upward. At all-time high of all times, we have 125,000 hospitalizations today. When you think of that, there's only about 900,000 total hospital beds in this country. And so the areas that are having lots of disease are really struggling with the number of cases. The disease is still very active in California, Florida, Texas, New York, and Georgia, and continues to be quiet in Vermont, Hawaii, and Southern Oregon. In Oregon, we're at 113,000 cases and about 1,500 deaths. They did not report the cases today, but in general, cases in Oregon, hospitalizations in Oregon, and deaths in Oregon are going down, so that's a good thing. Now, we're still watching very carefully for what's going to happen in the holidays, because what we've seen in Douglas County, we have 1,429 cases, and we recorded our 40th death today. We had been less than 10 cases a day over the last week, but then yesterday we were 27 cases. Today we're 34 cases. And those 27 and 34 cases, when we talk to people, so many of them are related to holiday activities, either church activities or social gatherings. And so we're starting to see a real uptick in cases. And this is a worry because remember, last week we went from the extreme range where restaurants were closed, gyms were closed, and then this week we're in the high range where those can begin to open. But if we continue to have 20 or 30 cases a day, we'll be immediately back in that high risk group and they'll need to close again. So please, please, please be careful over these holiday weekends not to cause more disease. And again, we've seen several large outbreaks in the last week. You'll remember before November, we'd had no large outbreaks. And then in November, we had a bunch of large outbreaks. December was quiet until this last week, where we've had a large outbreak from churches, several large outbreaks from gatherings, and we're having some cases at the Mission. So the Mission is our homeless shelter, and we're having some cases there. We think it's controlled at this point, but that's obviously a very complicated place for having cases because it's hard to quarantine and isolate. Well, the big news of the week, the other big news of the week have been the mutations. So the mutations, there are lots of mutations. So I have a friend who's a virologist, and they sent me the list of all the mutations. There are a zillion mutations. Most of these, though, are small and nonsense mutations, don't change very much. In the late spring and early summer, there was the B614G mutation, which changed the spike protein a little bit, and that made it more infectious, we thought, and that has now what has become the predominant kind. Now, over the last month or so, and maybe more than a month or so, there's been the new group of mutations. So it's a group of mutations that go together called the B.1.1.7 mutation in England, and then there's the 501.V2 mutation in South Africa. This is worrisome. This is worrisome because this does seem to be more contagious and spreading rapidly in England, and now in the United States, we have been able to find some cases here. Now, there's a little quirk in the way the PCR tests, and on the PCR test, there's a difference in the way this reacts to the S unit of the PCR test, and so we may be able to go back on some of those tests and find if this was here earlier. Now, some countries, especially England, does a lot of genomic analysis. That is, somebody's got the disease, they find the whole genome of the virus, and they look for mutations. In the United States, not so much. So in the United States, there are a couple of research centers that are doing it, but as a government, we've really not done this as a state or federal government, and thus we're a little in the dark about whether this genome is here. There have been reports of it being in Colorado among 2 National Guard members who helped out at a nursing home, and in California. But I think, given what we've seen from this virus and how fast it spreads, it may well be that this virus is more widespread than we know. In fact, I think it's likely that this virus mutation is far more widespread than we know at this time. Now, making it more contagious is problematic for a couple of reasons. One, it then makes it harder to control. The second is that you need a higher level of herd or community immunity to keep it under control. And so there are some real concerns with this. The biggest concern is will the vaccine work? And everything I've seen so far suggests that the vaccine still should work. And so we're keeping our fingers crossed with that. But I would expect a lot more work over this next week looking for neutralizing antibodies against this new mutation of the virus. But the best way to keep mutations from occurring is to keep down the amount of spread. And the best way to keep down the amount of spread is to keep down the number of cases. I think the other thing that really worries me, as we've talked before, is places where this disease can spread very widely, like in prison populations or in mink farms. And those places especially are high risk for developing mutations. So we've got to be careful. And then the good news of the week is vaccine. So vaccine has arrived in the community. So Mercy got 975 doses, and they're in the midst of distributing that. And then the ambulance service got 100 doses for the ambulance corps, and public health through Aviva got 200 doses, which we're giving to frontline healthcare workers. So it's been a little slow getting it up over the holiday week, but I think starting next week, we're going to see a lot more immunizations in Douglas County and a lot more immunizations in the state. And that's really a key. So the immunization strategy is really quite complicated. We're coming up with a graphic this week that'll hopefully make it easier. Now, we've made it complicated because at the federal level, rather than having group 1, 2, 3, and 4, they have group 1 and 2, and then divided group 1 into 1A, 1B, and 1C. And then the states have taken each of these groups and done it further. So the state now has 1A, and they divided 1A into 5 groups. And presumably they're going to divide 1B into a bunch of groups too. So it's going to be confusing because different people will be in different groups. So the 1A1 group are EMS, people in nursing homes, and hospital workers in frontline jobs. Makes tons of sense. 1B is going to be healthcare workers in less frontline jobs, but still in healthcare, and people in other long-term care facilities. And then as you move down that, it includes now everybody else in healthcare. And Oregon has decided to include teachers and early learning people in also the 1A group. Now, the states have some flexibility as to who's in what group, so we've done that. We expect to do most of the 1A in December and January, but this all depends on how much vaccine we get from the feds. And I check every day, and every day we can only know what we're going to get in the next 3 days. So there's no way for me to predict how much vaccine we're going to get in the middle part of January or the end of January. The most optimistic view is that in December and January, we'll be able to get the 1A group done. And then at the end of January or the beginning of February, we'll start on the 1B group. And then in the end of February, the beginning of March or whatever, we'll start on the C group. And then in April, we'll be able to start in the 2 group, which is the everyone else group. Now, again, this depends on so many things. It depends upon how much vaccine is out there. It depends upon people's willingness to get the vaccine. And it depends upon whether we learn something about the vaccine, which would change our minds. So early on, the only thing we found in the first 2 weeks of this being out is that there are allergic reactions. About 1 in 10,000 persons has an allergic reaction to the vaccine. All of the allergic reactions so far have been easily treated and the people have fully recovered. So we've not seen any other long-term issues or any other problems from the vaccine. And so that's a good thing. But as the vaccine now gets to more and more people, we've given it now to about 2 million people in the country. As it gets to more and more people, it would not be surprising to find some either minor effects or hope not, but you might see some other major or serious side effects. So let me go and see if we have some questions here. And we'll go through, oh my goodness, we got a bunch of questions. Ralph says, does Douglas County have sufficient personnel to administer vaccine quickly upon receipt? So at this point, we're only getting 200 doses a week. And so we have plenty of healthcare personnel to do it. If in the next month or two, you'd start getting 1,000 or 2,000 doses a week, or hopefully 10,000 doses a week, then we're going to need to expand to others. And we've already been working with all of the healthcare providers in the community, but as well as the pharmacies, as well as our EMS partners who are allowed to give vaccine, and also dentists who are allowed to give vaccine. We haven't done it with veterinarians yet. I don't think they changed the law yet for veterinarians, but I will check on that. So OHA reported a backlog of positive tests that came in for today's report. I don't know. So the story on the backlog on the test, so the test is kind of confusing. The way the tests work is that if you get a positive test, you're supposed to put it in this portal. The portal then goes to the state. The state then works on those and then sends them back to the county. Turns out that we have good relationships with almost all of our local people. And so when they get a positive test, they tell us right away. So we know about many of these positives way before the state does, and way before the state then reports back to us that they have a case. So on a typical day, let's say there's 20 that we get in the morning, we know about 17 or 18 of these from the day before. So we don't think we were terribly affected by that backlog of cases. But our case investigators are working. I know it's a holiday, but our case investigators are working today to go through those cases, and we'll know better. Lane says, were some of the numbers for today's test results from earlier in the year? I do not think so. I looked at the numbers here. They all had relatively late onset dates. We did have a time about 3 weeks ago where we had a couple of older tests. And so these were older positive tests that were reported They had the wrong county on them, so they went to the wrong county, and that's why we didn't see them. But they were all appropriately handled by the providers. So that did happen. We don't think it's happened now. So Carol says, is there any talk at the state about emergency authorization for training of dental hygienists, EMTs, and other healthcare providers? So there is certainly talk about dentists doing it. The law specifically does not allow dentists to delegate that authority to dental hygienists, but there's certainly talk. EMTs, there's certainly talk. But anyone else who's allowed to give vaccines should be allowed to do this. And again, right now, our problem is not enough people to give it. It's not enough vaccine. All right. So so it was a long question here. I can't quite read the whole thing, but about opening schools, and I think there's a real push to open schools, and the push to open schools comes from a couple of things. One is we are recognizing in the society that the online learning that many kids are doing is really not serving them well. So I told this story before, but I'm in the clinic every week, and when I see kids for their child visits, whatever I'm seeing them for, I'm usually asking how school is going for you. And for some kids, it's great. I saw a kid the other day. He said, oh, it's great. It's wonderful. I miss my friends a little bit, but I really like this online stuff. So I'm doing all the stuff from school, and I'm doing a college course too. It's like, okay, buddy, you're going to be fine with this. But then they see other families, and we ask them how they're doing. They say, oh, it doesn't really work. We don't have good internet. So we try and do things, but maybe 20 minutes a day. Those kids are going to fall way far behind. And we know that kids are falling behind. And so there is a move to open schools. The governor, the president-elect, even President Trump, Fauci, and all have really pushed to open schools. And the question is, how can we do this, and how can we do this safely? Well, I think there's a lot of data out there about schools now. The best data, I think, comes from a study in England that looked at schools, and they found that when there's not very much disease in the community, there's not very much disease in school, not surprising, and that when there is a case in school, it usually doesn't spread very far or very fast at school. And I think that's what we saw here. So we've had a bunch of school outbreaks, over a dozen so far, and we've had no cases where convincingly somebody else got infected. But there's a lot of people affected when there's a school case, right? Because when there's a school case, then all of the contacts of those kids are sent home. So we had one story where there was a school staff person, 300 people had to be sent home. So there's a lot of work and a lot of disruption with that. So I'm still not sure what's going to happen about schools. Now, again, one of the things we've talked about before is that people have different risk tolerance. Right? So there's some people who think that jumping out of a plane with a parachute, scuba diving super depths, or riding a motorcycle are safe enough for them, and they do it. And then there are others of us who think, ooh, that's a little risky, I don't want to do it. Similarly with COVID, there are some people who are out there partying around that I look at and I think that, ooh, that's way too dangerous. And there are others who've not left their home at all because they're very scared and they don't want to get it. And then there are some people who are in between. And so the risk tolerance for the students and the teachers really needs to be taken into account. We have lots of teachers who say, look, yeah, there's some risk, but I'm willing to go ahead and do it. And then we have others, either because they're older or sicker, or they're living with people who are older or sick who are very worried. And my sense is that whatever we do with schools needs to accommodate people's different risk tolerances. So if there are teachers who really feel it's too dangerous for them to go back to school, they really shouldn't. And if there are students who feel it's too dangerous for them to go back to school because they're living with grandma or living in a big house where there's lots of people, then they shouldn't. But that if there are people who feel that this is acceptable risk and the numbers are low enough so that it is an acceptable risk, I think opening schools is probably okay. So Betsy says, is there anything being done to help the homeless or protect them? Well, the people we talked about before are people in the shelter, and there are things that the shelter is doing, but the shelter is a hard way to do it. Actually, for people who are truly homeless, we are working with them. We got a grant from the Knight Foundation to work with that. But remarkably, we've not seen much disease among those who are living outdoors. And that, again, is not surprising. Living outdoors is much safer than living indoors people are living outdoors tend not to have lots of indoor gatherings. And again, almost all of our cases can be traced to indoor gatherings. So tragic as it is to be houseless in this case, to be camping next to the river actually is somewhat protective during this. So yeah, we are working with that. And Betsy, if you're interested, next week why don't you get in touch with Kristen, who's helping us with that grant. So Rebecca says, who's getting the vaccine right now? The people getting the vaccines right now are the people in that 1A group, which are nursing homes, and we've had a bunch of people at our nursing homes get vaccines. EMS got some vaccines, so they'll be distributing them this week. And public health got some vaccines delivered to Aviva. And so Aviva and some of the other larger clinics in town are going to be starting to immunize people who are seeing sick people in the clinic. So urgent cares, people are doing same-day appointments, those kinds of people. I'll probably get mine next week because I'm certainly seeing some sick people. And so we'll start with that. The next group after that are going to be people in other long-term care and people who work in healthcare but aren't necessarily right up front with patients. So why are you saying December when it's all January? Well, you know, I'm old, so it takes me a little while. I will probably write 2020 on my checks for the next 2 or 3 weeks. Yes, it's December now, but the stuff got delivered in December, and it's going to be December and the early parts of January. So Dawn Bean says, is there any way to determine if the vaccine will cause birth defects? Sadly, no. So birth defects are an incredible concern. So as a pediatrician, the two big causes of death in pediatrics are prematurity and birth defects. So we really, really, really worry about birth defects. And unfortunately, it is really hard to study birth defects because even things that cause birth defects commonly don't cause them in a high percentage of cases, sometimes just a few percent of the people. So for people who are older will remember there was an incredible tragedy in the US with a drug called thalidomide. So thalidomide was a drug that was used as a sleeping pill. It's actually used now for other things, but it was used as a sleeping pill. And what they found is that moms who took it during certain parts of the pregnancy the kids had limb defects where they were missing arms or something like that. Truly a terrible birth defect. It took us a while to figure that out because you had to take it at exactly the point in pregnancy where that limb was developing. If you took it a day earlier or a day later, it didn't seem to have any effect. And because of that, it took a long time to figure this out. And so unfortunately, figuring out birth defects is usually a retrospective thing. And so what we're doing with this is we are going to be incredibly carefully following birth defects starting today and in the future to see on these birth defects if there's an increase in one kind or birth defects overall related to the vaccine. I don't think so. So again, the way this works is these are messenger RNA vaccines. So to go back to the genetics thing that we maybe didn't all pay full attention to in school, there's the DNA, which are the chromosomes that we have that have the material that has the master plan for what goes on. When your body wants to make a protein, what it does is it makes something called messenger RNA. So messenger RNA is a copy of the DNA. That messenger RNA now goes to the ribosomes where the protein is made. mRNA does not last very long. mRNA lasts hours to days and not longer than that, and then gets degraded. So it only lasts for a short time, so it's not around for a long time. And we think it's only going to go to those cells where you get the shot, not necessarily go to the baby and cause birth defects. So you could never say never with birth defects because birth defects are almost always determined retrospectively, but other mRNA vaccines have not been associated with birth defects. Now, they've also not been given to a lot of pregnant women. And so I think this is an unanswered question. And again, as I've said again and again, not everybody needs to get immunized, right? So we don't have to have 100% immunization for this germ to go away. If we get 60 to 70 to 80%, depending upon this new mutation, of people immunized, we're going to be fine. Well, only about 2% of our population at any point is pregnant. So we don't have very many people who are pregnant at any one time. And those 2% should get it. The people with who've had an anaphylactic reaction in the past, they might hold off, or people who are lactating might hold off, or people with heart transplants might hold off. Well, that's about 5% of the total population, which leaves 95% of the rest of us who can and should get the vaccine. So Lori says, where are they going to give the vaccine so that they're prepared for an anaphylactic shock? So anaphylactic reaction is this reaction that you get usually within the first 10 or 15 minutes after getting the shot, where you get hives, shortness of breath, low blood pressure, and you may get wheezing or facial swelling. It is pretty horrifying to see. I've only seen it a few times. Pretty horrifying to see. And the treatment of this is a shot of epinephrine, Benadryl, and then other supportive care. So again, we in the past have given vaccines in places like the fairgrounds and whatever else, but with this level of anaphylactic reaction, which is not very many, 1 in 10,000, but we expect to give 160,000 doses in Douglas County. So we would be not surprised if we would have 16 anaphylactic or anaphylactoid reactions in the county. And so we're at least starting to do this in places where you could be resuscitated. So EMS obviously is probably the best to do this. This is what they do. Doctors' offices are set up to treat anaphylactic reactions. Dentist offices are also set up to do that because dentists give you Novocaine or whatever where you could have an anaphylactic reaction. So I'd recommend any place you do it, be ready to treat anaphylactic reactions. We're going to have to see what happens if we go to, for example, we talk about veterinarians or at the pharmacy or whatever. We're going to have to see what happens there. But at least in the beginning, we're going to be giving these all in doctors' offices. And when the vaccine is handed out, we're going to be sure that they have not only everything ready to treat anaphylaxis, but that they've actually drilled what would happen if somebody had one of those symptoms. So Julie says, do you know if anyone has received a second dose yet? I don't think so. I think the first doses in Douglas County, first doses in Oregon were given between about the 16th and the 20th. So you don't get the second dose of the Pfizer vaccine for 3 weeks. So I don't think anybody's due for it yet. Yeah. So Veronica says, why did we open up some things today when we know that people were exposed to gatherings will probably be going to restaurants? This is always complicated about the timing. Right? You don't know what's going to happen with this. So the state came up with guidelines and we follow those guidelines. So someone says, I work as a dental assistant lab instructor. So a dental assistant lab instructor would be considered a healthcare worker. Dentists are going to be in, and again, this is confusing, group 1A, subgroup 4, and we think 1A, subgroup 4 is likely to get vaccines sometime at the end of January. What's going to happen for places that, the first groups are places that already give vaccines, the hospitals, the clinics, and whatever else. But we're going to get, as we get further down, to places that don't give vaccines, like dental assisting labs, like marriage therapists, like physical therapists, and we are going to be working with those clinics that do give vaccines to work with those clinics who need vaccines but can't get them, to work with those other clinics and kind of buddy up to do it. Again, we don't think January is really going to be the issue. We think we have plenty of people to give the vaccine in January. We think we're just going to be low on doses, right? We think there's probably in Douglas County, we don't know the number totally, because the definition of healthcare workers is kind of broad, but we think there's probably about 10,000 in this group 1A, if you include teachers, early child care, all healthcare workers. We think there's probably there may be as many as 10,000 people in the county who fit in one of those areas. Well, at 200 doses a week, it'd take a long time to get to those 10,000 people. And again, I have no visibility whether in the later part of January, instead of getting 200 doses a week, we'll get 2,000 doses a week. So we're working on this every day. I spent several hours today working on this because there's a lot of details to figure out. So someone said they're a hospice nurse, not associated with a hospital. So hospice workers not associated with a hospital will be as that similar to the dental lab instructor, that you will work with your employer to buddy up with someone else who will give the vaccine, likely another clinic. So we've heard from many of the employers of these other healthcare workers, but we're not sure we've heard from all of them. And that's our job for this first week in the new year, is to find out all of those places that have healthcare workers and are not able to give the vaccine. Last week, we worked on all of the places that had healthcare workers and could give vaccine. This week, it's going to be all of those people who have healthcare workers and can't give vaccine. And we're going to try and match them up. So Debbie says, I'm a substitute teacher. When would I be able to receive the vaccine? I think we're not parsing it out between full-time and substitute. So I think substitute teachers would get it around when the teachers are going to get it. And we think the teachers are going to be in group, I know this is confusing, 1A wave 5. And we think 1A wave 5 is going to be the last part of January or the first part of February. Now, we've been working already with the Educational Service District, or ESD. They already have a plan once they get vaccines to be able to give the vaccines for teachers and staff. And so they're very well set up. And I think that's going to work pretty well. So a 67-year-old with diabetes won't get his vaccine until February or March. Sadly, I think it's even later than that. So a 67-year-old with diabetes is in group 1C. And again, remember 1A started in December, it's going to go through January, early February. Group 1B, probably February through March. So the earliest would be February. So yeah, that does stink, doesn't it? You would think in a country such as ours, we could do this sooner, but there's just not enough vaccine. And using the priority that the CDC set forth, a 67-year-old with diabetes will be there. Now, the caveat to this is that the states get to move the rules a little bit. And there's a group that's going to be meeting on Tuesday to go ahead and review this. And they may put somebody with those conditions a bit higher or a bit lower. I'm not sure what they're going to do, but they're going to be working this week to do it. So Laura said, I had a reaction to Prolia. Should I be cautious of the COVID vaccine? Well, there's nothing in the COVID vaccine which is in other vaccines you would have gotten or the medicines you would have gotten. So you can't tell, but people who have reactions to one thing are much more likely to have reactions to something else. So if you've never had a reaction to anything, you could still have a reaction. But if you said, oh, I had a bad reaction to tetanus shot, I had a bad reaction to this medicine, then you're probably at high risk from having a bad reaction to this. So again, this would be one I would talk about with your doctor, and everybody should be cautious. Yeah, so Heather says, how is the new, more contagious strain being diagnosed? Is it with the PCR test we currently use, or is it an extra test that they're doing? The answer is both. So the extra test that they're doing would be to find the virus and do a genomic analysis and see if the genomic analysis did that. That is not something we do anywhere in Douglas County, and only a few places in the state do this, but that would be the way to tell for sure. Now, there's a funny little quirk of this, is that the typical PCR test we do reacts with 3 different probes, and this new variant only reacts with 2 of those probes. So it doesn't react with the S probe. So the ones that are S deficient are much more likely to be this new strain. And that's basically, remember in England, they said, oh, this is 56% more infectious than the other. They did it on the basis of the increasing number of these S deficient probes. It's fairly complicated, but what I would have you do, the best explanation I saw of this is a newsletter written by a fellow named Morris Sharp. And so if you will Google his newsletter, he has a beautiful analysis of the S deficient things. He is a PhD guy, from University of Chicago, and is brilliant and explains it very well, much better than I could. So if you want it, his name is Morris Sharp. So Brooklyn says, is the new strain more deadly? We do not think so. But again, a little hard to tell for sure. If it was more deadly, what you would expect to see then is that the case fatality rate would go up. That is the number of people who are diagnosed and the number of people who die, that the case fatality rate would go up. And since the beginning of this, the case fatality rate has steadily been declining. And it's steadily been declining because we have treatments like prone positioning, like Decadron, like remdesivir, avoidance of intubation, better use of anticoagulants. So the numbers are steadily going down, but we're very carefully looking to see if there's a spike in the case fatality rate that would suggest it is more deadly. So far in England, where they've seen this new mutation for a while, they have not seen that. Yeah, so Veronica says, could you put on the site who are in the different stages? And that's this graphic that I spent much of yesterday trying to work on. The problem is it is so dense. There's like, you'd have to really fully understand this, like 50 pages to read. And as you know, we've tried to do these infographics that you can look at one page and see it. And we tried to put it on one page, but it's pretty hard to do. But we have some geniuses who work at that. They're going to do a good job. Yeah, I don't know about this one. So my daughter's an RN. She got the Pfizer vaccine. She had hives within an hour, an itchy, burning tongue, and then aches, fever, malaise. Well, that's a reaction. So really, she needs to talk to her doctor about getting the second dose and go through everything that happened. That is a bit concerning to have that kind of reaction. Presumably, she got through it, but while you're having this reaction, there's a fair amount of anxiety that goes with it. So Nathan Ham said, is there anything we should do in dental offices to help get our staff set up with clinics that do administer vaccines? So actually, I think the dentists are probably going to start administering vaccine. I've been working all week with Dr. Peterson, who I understand is in charge of the local dental society, to work with the different dental offices so that the dental offices could also administer the vaccine. There's some paperwork and some training that they need to do, and we've been working to see if we can get them through this training and paperwork so they can do it themselves. So we think with this that dentistry would actually be a great place to get people to get vaccines. So what we're hoping for is when we come to February and March and we have a lot more vaccines and a lot more people getting the vaccines, we're hoping that there's 50 different places in town you can get it. Any doctor's office, any pharmacy, any dentist's office, maybe at the ESD if they're doing it for teachers, all of these different, maybe all of the fire stations even, because the EMS is allowed to give this vaccine. So maybe we could get to a point where there's 30 or 50 different places to get the vaccine, in which case if we have to give 1,000 a day, which I think is our bogey, then each of those places only has to give 20 or 30 a day. If you only had one or two places giving the vaccine, you have to give a ton of vaccine. And so what we're hoping is that we can get lots of different places. So I'd have you work with Dr. Peterson. He's really working hard on this. So Carmen says, is the Pfizer vaccine interchangeable with Moderna? Yeah, we do not know. Obviously, this is something that hadn't been studied. To study it, neither of the vaccines was approved at the time, and they only did Moderna or Pfizer. I went to a conference last week where somebody pondered that possibility and said they didn't know. And so right now, the recommendation, if you get one, you'll get the second. So Sandy said, is there a guarantee that our second dose will be there when we need it? Well, there's no guarantees of anything, but they are holding back the second dose. So when Mercy, for example, gets 975 doses on a certain date in December, 20 days later, they'll get another 975 doses for the second dose of that first group. Similarly, when public health gets 200 doses, they're holding back 200 doses for the 4 weeks later with the Moderna vaccine. And ESD concerning teacher vaccines, does that include Head Start teachers? I think so. I think that this is people in early child care, early childhood education, and teachers. So I think it's all of those. And so Karen says, is there an online site that lists the vaccine groups and progress made in moving through those groups so we don't have to keep bugging me? Don't worry about bugging me. This is what I do. But we'll get a much clearer thing. There is. I mean, if you go on the Oregon vaccine site, it's all there. But there is so much stuff there, and it's so confusing. So if you want to look at it there, it's actually really quite good. That really is quite good. But we're going to try and put together a clearer metric, and we're going to try and put together, like when they're raising money, they have these thermometers that go up along the way. It's probably not going to be quite that simple. But what we're hoping to do is to have a left to right thing, and we can sort of show where we're at this stage. Right now, I would say we're in the midst of 1A1. So 1A1 is hospital workers. Mercy's already given some. EMS, they had the vaccine. I think they're giving some this weekend, but certainly within the next week. There's public health vaccine that goes to other urgent cares. We expect to get that done this coming week. And then nursing homes, which I know some have already been done. So I think we're in the midst now of 1A1. But you're exactly right. We need to have an easy graphic to say where are we and when can we expect the vaccines. So Jennifer says, I called the 2 urgent cares in Roseburg and was told there's a national shortage of rapid COVID tests, and you can't get one here unless you're symptomatic. Well, that's so there are several rapid tests. One of these is called the Sofia Quidel. There is a national shortage of Sofia Quidel. The second one is BD Veritor. The BD Veritor test, there's not a national shortage, but there's a delay in delivery. And then the third are the Binax Now card tests. They're very simple, like a strep test. There is no shortage of the Binax Now test. One of the urgent cares in town did have a shortage, and we delivered to them this week many boxes of the Binax tests, so they could use the Binax tests until they got their Sofia tests back. But I will tell you, in the rest of the state, in the rest of the country, testing is still a mess. It should be very easy to get a test if you're symptomatic. I as shorthand say, it should be as easy to get a test for COVID if you're symptomatic as it is to buy a lottery ticket. Well, it's nowhere close or as easy yet, but that should sort of be our goal. We shouldn't have anybody who's symptomatic sort of wait around and think, well, I'll go to work this week and see what happens, and then spread it to a bunch of people. People who are symptomatic should be able to get treated right away. So if you talk to an urgent care and they say they don't have them, we have plenty of Binax Now available. In fact, I have one on that. Actually, my computer is resting on a box of Binax Now tests to keep it up like this. So there are plenty of those tests. So we've already been in touch with the urgent cares yesterday and with other practices to get them this test. So Jennifer says, are you concerned with the new cases in Reedsport? Yeah, there are several cases in Reedsport. We think most of these cases in Reedsport are from Coos Bay. So there's several big outbreaks in Coos Bay. And as you know, there are many people who live in Reedsport and work in Coos Bay, and we think they brought it back. We don't think there's sustained transmission in Reedsport, but we're worried about everywhere. I mean, we are worried about everywhere in the county because it doesn't take very long to go from a nothing to a huge outbreak. So when Forest Glen had their outbreak, it went from nothing to 60 in seemingly a heartbeat. And so these things can spread very quickly. This is a funny disease. We have so many people who get it, don't give it to anybody else, they don't even give it to their spouse. I mean, how could that be? There's almost no disease that wouldn't do that. And then others where one person gets it and they give it to 20 or more others. And that's why this disease is so very hard to do, because of the great variability in transmission. So Carol says rapid testing is most accurate for those with symptoms and less so for non-asymptomatic people, and that's indeed true. So asymptomatic, the whole deal with asymptomatic testing is kind of up in the air. And asymptomatic testing is reasonable in certain situations. No question about it. It's the way you figure out how much disease is there. It's a way, for example, if you are a contact of the case, you can find out if you got the disease as a contact of the case. So we think that symptomatic people should all get tested. We think that people who have a specific risk factor should get tested. So so if they're in contact with a case, or if you really, really want to know, you should get tested. But just general asymptomatic testing of the population is I'll say it's controversial. There are some who believe that's the way out of this. I think they are totally wrong. But this is a thing we disagree about. So again, testing for symptomatic should be far and away our highest priority, and we shouldn't even think about testing asymptomatic people until every symptomatic person can get an easy, quick, and accurate test. The next level we should go down to then is contacts. So asymptomatic contacts of cases should be tested, and then people in some high-risk areas like in correctional facilities and whatever should get tested. But sort of general asymptomatic testing of, for example, everybody who went to the Rose Bowl today. So the Rose Bowl, which is going to be, I guess it's on now. So the Rose Bowl, they let 10,000 people into the stadium. So let's say you said, we're going to test everybody when they get into the stadium, and we'll want to get the results of their test right away. So we're going to have to use one of the rapid tests. So the rapid tests are good. They're 90+% sensitive. That means if you're sick and have a positive test, 90% of the time it's going to say you have the disease. So that's great. And it's about 90 to 95% specific, meaning that if it says you don't have the disease, you don't have it. But a couple percent of the time, maybe up to 5% of the time, it will tell people who don't have it that you might have it. So the 10,000 people who went to the Rose Bowl today, if you'd had a kiosk out front and tested everybody before they went in, 5 of 100, which means then, and there's 10,000 there, 500 people. Did I do the numbers right? Yeah. 500 people would be told you have a positive test when they don't. What do you do with those 500 people? You obviously wouldn't let them in the stadium, but then do you have them quarantined for 2 weeks? Do you have them do that? And it depends upon what the background level of disease is. Now, if 20% of the people in the population have the disease, so presumably 90% of the 20 or 18% of the people would be told they had the disease correctly. 5% would be told incorrectly. Well, still the number of people correctly told is far greater than the people incorrectly told. But if the disease is low, let's say there's only 1% true positives, then you'll pick up that one person. But for every 6 people you tell, only 1 will really have the disease. So there's really just a statistical problem with doing asymptomatic testing. The places that have done it the best do multi-stage testing, where they do a rapid test like a Binax and then followed up with a rapid PCR. That takes a tremendous amount of sophistication to get that going, and the yield on that is pretty low. So again, the first thing we should do is that people who are symptomatic should stay home and get a test. People who are contacts of symptomatic people in high-risk situations should get tested. And again, they can get tested with any of the tests. Certainly a PCR is a bit better, but they're much slower than the other test. All right. So Robin says, has the Reedsport Hospital received vaccine? So I had an email Sunday, from Paul Connolly, who's their new head, and we got them set up with the state, and we're told that they're going to get a shipment of Moderna vaccine next week. The shipments of Moderna vaccine come in at hundreds. So each box is 10 vials, 10 10-dose vials in a box. The minimum shipment is 100 doses. So, 100 doses for Central Douglas County is not a lot. 100 doses for them is going to get them started off pretty great. So that's great. So they are getting started. They had not made this easy for providers. The sign up for this COVID vaccine, you'd think it would be like, hey, we want you to sign up. We're going to make this as easy as possible. If you want to see paperwork at its best, look at the COVID-19 vaccine provider agreement. More complicated than your taxes, to sign up to do this. And these are people who already get vaccines. So this is not like the garage down the street saying, hey, you think I want to get vaccines? These are people who already get vaccines every single day. And they made you go through this incredible set of hoops and sign away your life to go ahead and be a COVID-19 vaccine provider. And so that has been one of my great frustrations, that at a time when we should be making this as easy as possible, we seem to have been making this as hard as possible. So Kathy says, have the patients on the COVID ward at Rosehaven been given phones yet? I do not know. And then the second thing is, someone says that if they've had a positive test, they will always have a positive test. Well, it matters which kind of test you're talking about. So if you're talking about a rapid antigen test, people who test positive for rapid antigen test typically are negative on the rapid antigen test 8 or 10 days later. For people who have a positive PCR test, they test positive on the PCR test for an average of 24 days after their first PCR test, with a wide range. So we've had some people who are negative a week later, we've had some people who are positive months later, but an average of 24 days. If the test that they're going to get is an antibody test, so the antibody test is your body's reaction to the vaccine, we know that about 90% of the people who get the disease will have a positive antibody test after they get the disease, and most of those positive antibody tests will persist. Now, there's some question about whether those antibody levels drop with time or whatever. So it is certainly possible, if you had a positive antibody, if they were talking about antibody tests, then yes, you might have one positive for a long time. If they were talking about PCR tests, the answer is you might still have a positive PCR test for a while, but certainly not for always. All right. Well, a couple of other interesting things we've read this week. You know, we're at the end of December. We got to see what the toll of COVID was in December. So using the numbers I got, I think it was 72,000 people died of COVID in December. 72,000 people died of COVID. Let's put this in. So people die of stuff every day, obviously, and people are born every day, and that's how the world goes. But if you look to see how many people in December died of heart disease, in an average year would be 55,000. Of cancer, in an average month, would be 50,000. Of accidents, about 15,000. About COPD, about 14,000. Of stroke, about 13,000. And of Alzheimer's, about 10,000. In December, 72,000 people died of COVID. Now, people always say, well, maybe they got run over by a truck and they were done as COVID. I mean, something like that might exist, although I've not yet seen it. But still, the leading cause of death in December 2020 is COVID. I mean, that is really, really tragic. That is really tragic. I mean, think of all of those people who have cancer who we pray for. Think of all the people who have cancer that we talk about lives cut short. The people who die of cancer are about the same age as people who die of COVID. The people who die of heart disease about the same age as people die of COVID, mostly people in their 50s, 60s, 70s, and 80s. And so this is really a tragic toll. Now, people have always said, oh, many of those COVID deaths are not really COVID deaths. And there was a news program that somebody sent me last week, and there was a state senator from Minnesota saying, well, somebody was in a car wreck and they got called a COVID death. And I don't know. I don't have access to the Minnesota records and see. But still, that could have been a COVID death. Let's say you got into a car wreck and you broke your leg and you were in the hospital, and then they found out in the hospital that you had COVID, because before you go to the OR to get your leg fixed, they would check you for COVID. And let's say you had COVID, and then later on you died of respiratory distress in the hospital. Yes, you were in a motor vehicle accident, and the motor vehicle accident actually would be recorded on your death certificate, but the cause of death would be respiratory distress, secondary COVID, complicated by a broken leg, complicated by a motor vehicle accident. So again, the people who are saying these things probably themselves never figured out a death certificate. So, I talked to the state medical examiner, I was just on the phone with him yesterday, about doing this, and we don't know of a death in Oregon that is not really truly a COVID death. Now, people get the sense, from watching all these Datelines and whatever, that every case has an autopsy and 3 forensics pathologists looking at every little thing that goes on. That is clearly not the case. Only a tiny, tiny, tiny fraction of cases of deaths in Oregon are autopsied. So almost everybody who dies in Oregon in a non-suspicious manner. Now, suspicious deaths do get autopsied, but non-suspicious deaths don't. Very few of those get autopsied. And so many times it's a guess, right? So a 75-year-old person is at home and they're found dead in bed the next day. They don't do an autopsy to see what killed them. They'll usually talk to the doc, and the doc says, well, they did have, I had been seeing them for chest pain, so maybe they had a heart attack, so they'll write that down as a myocardial infarction without ever exactly finding the reason. And so not every case with COVID gets autopsied. And so, could there be something else? Yes, but that doesn't detract from, let's say these are even 1 or 2, 5% off. 70,000 deaths a month is a lot of deaths. So it is one of our deadliest months. When we look at the number of people who died, it appears that December 2020 will be the deadliest month ever in the US. Now, correcting for population, back in the 1918 pandemic, there were more deaths for the population, but that was really an apocalyptic time, and we really, really, really could avoid this. Now, back in 1918, we didn't know much about disease. We had no vaccines. We didn't have intensive care units. We do now, and so we really, really, really should be working hard to keep the disease levels down and working really hard to get everybody vaccinated, so that when I do this on the next holiday, and somebody said one of the great benefits is the next national holiday is Memorial Day, that when we do this the next time on Memorial Day, we'll be able to say, we've looked at Douglas County, we're down to less than 5 cases a day. There are very few restrictions. Vaccine is widely available. We're up to now 63.4% of our population being immunized. Still want to get that next 10%. And we really want to do that by the next holiday after that, which is 4th of July, so that by the next holiday after that, which is Labor Day, we can say we're at a level of immunity where the disease, we're still seeing some cases of disease from travel, but overall the disease is well under control, and we're able to fully open businesses and open schools, and that's what the goal is. What do we have to do between now and then? We have to do the common sense stuff, really avoid the gatherings, truly wear your mask, stay distance. If you're sick, please stay home. If you are sick, call your doctor and get tested and get the vaccine. And then this is time we really have to stop sniping at each other. I know people disagree with lots of things, and certainly I disagree with stuff, but this time we really have to work together, because if we do this, we can meet my goal here, which is a very optimistic Memorial Day talk, and an even more optimistic 4th of July talk. Well, I hear the chimes in the background, which means it's 5 o'clock, and it's time for me to go. Again, this is Dr. Bob Dannenhoffer. Be kind and stay safe. Thanks. We'll do this again next Tuesday. Bye-bye. All right, so we'll save some of these. Okay, what'd you think?